So now that we've discussed the pre-renal AKI, which is a problem with renal hypoperfusion, as well as the intra-renal AKI, which is a problem with the kidney itself, we can go on to talk about the post-renal AKI, which is a problem with obstruction of the urinary outflow tract. This is a stylized diagram showing the renal or urinary tract, which shows the kidneys here, the renal parenchyma, as well as the renal pelvis, going into the ureter, going through the ureteric orifice, into the bladder, and out of the bladder outlet through the urethra, which in males is surrounded by the prostate. Obstruction at any point in this tract will lead to proximal dilation of either the ureter or the renal pelvis, known as hydroureter and hydronephrosis respectively, which is readily detected on imaging with either ultrasound or CT. This back pressure, if severe, can also lead to a reduction in the glomerular filtration rate, and therefore lead to a post-renal AKI. Common sites of obstruction include the bladder outlet, particularly in males, where prostate pathology, particularly benign prostatic hyperplasia, can lead to narrowing of the prostatic urethra and the bladder outlet, and therefore lead to an obstruction of the urinary outflow. Similarly, tumors that grow around the ureteric orifice can also lead to a reduction in the urine outflow, as well as ureteric and renal stones, which, if are large enough, can lead to obstruction of the outflow tract. Intra-abdominal tumors can also lead to extrinsic compression of the ureter, which can also lead to outflow tract obstruction in a post-renal AKI. In these situations, the diagnosis is confirmed with imaging, and the treatment is to relieve the obstruction, which acutely usually means insertion of an indwelling urinary catheter if the level of obstruction is at the bladder outlet, and the use of medications such as tamsulosin and dutasteride, as well as surgical interventions like a transurethral resection of the prostate, may be useful if the pathology is benign prostatic hyperplasia. Other interventions such as a ureteric stent may be necessary if the pathology is an obstructing ureteric or renal stone, and laser lithotripsy may be required if there are remaining stones in the tract. If the pathology is an intra-abdominal tumor, then surgical resection may be required to remove the tumor and therefore relieve the obstruction, and systemic or radiotherapies may be required to shrink the tumor and relieve the obstruction that way. If stenting is required to relieve the ureteric obstruction, the stent can be placed with a retrograde approach through the urethra and going up the ureter this way. And if this is unsuccessful, then an anterograde approach can be used, where we can go through the renal parenchyma and insert a stent in an anterograde fashion. A nephrostomy tube is usually placed in this situation, which will act as a backup outlet to relieve the urinary outflow if the anterograde stent is unable to relieve the obstruction. Once the post-renal AKI has been treated and the obstruction has been relieved, it is important to look out for a complication known as post-obstructive diuresis, which is a form of osmotic diuresis. While there are many mechanisms involved, one of the mechanisms is that there is a retention of urea within the renal tubules due to the obstruction reducing the glomerular filtration rate. And upon relief of the obstruction, the urine that is concentrated with urea will lead to an increased amount of water being excreted as well, because urea is osmotically active. This can therefore lead to a markedly increased urine output of many liters per day. And so to prevent dehydration and electrolyte disturbances from the post-obstructive diuresis, you need to give adequate volumes of intravenous fluids to match the high urine output, where the volume of intravenous fluids that is given is usually between 50 to 100% of the urine output volume, ideally titrated every hour. Now that we've discussed the pre-renal, intra-renal, and post-renal acute kidney injury, we can summarize this information in an approach to AKI. Like everything in medicine, it's very important to take a good clinical history and do a good physical examination, because there are often a lot of clues in the history. For example, there may be a history of gastrointestinal losses from diarrhea or vomiting, or a history of recently starting nephrotoxic medications. They may have more chronic features of an underlying autoimmune disease from which the AKI may be related to. They may have a history of known benign prostatic hyperplasia and present with acute urinary retention, which would make a bladder outlet obstruction a likely etiology for a post-renal AKI. Clinical examination can help determine if the patient is dehydrated or fluid overloaded, and may reveal signs that support a connective tissue disease diagnosis. As discussed, the urea-creatinine ratio can be a useful tool to help distinguish a pre-renal from an intra-renal acute kidney injury. It is also important to know the electrolyte levels, particularly the potassium, which can become elevated in an acute on chronic kidney injury, and potentially lead to life-threatening bradyarrhythmias. Markedly elevated phosphate levels on presentation may be a sign that there is a degree of chronicity to the kidney injury, as phosphate retention is a feature of severe chronic kidney disease. In contrast, low potassium, phosphate, or magnesium levels may be a sign that the patient has had significant gastrointestinal losses. If the AKI appears to be intrarenal, or you're trying to distinguish a pre-renal from an intrarenal AKI, or the AKI is particularly severe, then doing urine investigations would be appropriate, such as a protein or albumin to creatinine ratio, essentially to look for proteinuria, which may suggest nephrotic syndrome more so than nephritic syndrome, and urine microscopy to look at various different casts, which can clarify the etiology, for example, eosinophilic casts, which may suggest acute interstitial nephritis, or to look for dysmorphic red blood cells, which would suggest hematuria and therefore nephritic syndrome. As discussed, doing a urine sodium and urea to calculate the fractional excretion of sodium and urea respectively may be useful to distinguish a pre-renal AKI from an intrarenal AKI. If the patient has signs and symptoms to suggest an underlying autoimmune etiology, then autoimmune serology would be appropriate. If the patient has hypercalcemia, lytic bone lesions, or anemia to suggest an underlying plasma cell dyscrasia, then it would be appropriate to do a serum electrophoresis as well as free light chains to investigate for this. Renal imaging, whether it be an ultrasound or a CT scan, can be very important in the workup of an AKI, because you can look at the renal parenchyma to assess for lesions, polycystic kidney disease, and the cortex thickness, which can determine whether or not a renal biopsy is amenable. You can also look at the size of the kidneys, which are normally about 10 to 12 centimeters in diameter, where a kidney size that is much less than this would suggest a degree of atrophy and therefore a degree of chronicity to the kidney injury. Imaging can also assess for hydronephrosis and hydroureter, and in the case of a CT scan, you may also be able to find an extrinsic compressing mass or a kidney stone, which will help clarify the diagnosis of a post-renal AKI. If the diagnosis remains unclear after doing all of the above investigations, and the kidney function appears to be worsening, then you may have to proceed to a renal biopsy to clarify the diagnosis, if the patient is amenable or suitable for a kidney biopsy. Now, in terms of the management, it's important to, in the first instance on presentation, try and identify and withhold any potentially nephrotoxic drug, which can be anything ranging from antihypertensives and diuretics, non-steroidal anti-inflammatory drugs, to things like chemotherapy drugs such as cisplatin. It's also important to try and identify any potential offending agents such as flucloxacillin or other antibiotics that may cause an acute interstitial nephritis, and avoid using any potentially nephrotoxic drugs when you're trying to treat these patients. Patients with AKI can present with an abnormal fluid status, particularly in the setting of a pre-renal AKI where they may be very dehydrated, and so you can treat this by giving them intravenous fluid. In contrast, patients with a severe or intra-renal AKI may be fluid overloaded, and therefore, particularly if they have signs of acute pulmonary edema, these patients need to have diuretic therapy, particularly with loop diuretics, to prevent worsening, potentially life-threatening fluid overload. But when giving diuretics, it's important to not overdose the diuretics, which can then cause hypovolemia and lead to a pre-renal AKI. Ultimately, if the patient has an abnormal fluid status, you should try and treat the abnormal fluid status and always aim for euvolemia. If the AKI is severe, you need to determine if the patient will need urgent dialysis, not based on the creatinine or urea number alone, but instead based on features which suggest compromised renal function. So for example, severe electrolyte disturbances, particularly hyperkalemia, signs of severe uremia, intractable fluid overload, or severe metabolic acidosis despite bicarbonate therapy. If dialysis is required, then you need to try and get urgent vascular access, usually through a central venous catheter, and initiate dialysis as soon as practically possible. An arterial venous fistula or graft can be used if the patient already has this, but the formation of an AV fistula or graft is not an option in the acute setting, as it can take several weeks for an AV graft and several months for an AV fistula to fully mature and be able to be used. And ultimately, as with most things in medicine, you have to try and identify and treat the underlying cause, whether it be fluids for a pre-renal acute kidney injury from dehydration, immunosuppressive therapy for a glomerular nephritis with an intra-renal acute kidney injury, or relieving the obstruction with a urological procedure in the case of a post-renal AKI. And with that brings us to the end of this video. I hope you now have a better understanding of renal function and acute kidney injury in terms of the underlying pathophysiology and the clinical application. This slide on the approach to AKI summarizes the key points which we've discussed throughout this video for you to review. If you like this content, please leave a like, comment, and subscribe to the channel. All the best.